So my name is Robert Gagel. I'm a professor of medicine and endocrinology at the MD Anderson Cancer Center in Houston, Texas. Yeah, so medullary thyroid carcinoma derives from a specific cell type that happens to exist in the thyroid gland. It is not a cell that produces thyroid hormone, which describes the predominant cell type in the thyroid, but rather produces a hormone called calcitonin, which actually is involved in the regulation of calcium metabolism. So it just happens to be in the thyroid gland, although it has nothing to do with the thyroid gland's function. And medullary thyroid carcinoma is a cancer that is produced when one of these cells, which we call C cells, transforms or develops a genetic abnormality that causes it to grow abnormally or not to die. And eventually it can grow to be sizable and spread outside the thyroid gland and to spread to other organs such as the lung, liver, and bone being the most common. Definitely. About 25% of medullary thyroid carcinoma occurs in the context of a familial setting, meaning that it's passed from a parent to a child. And we have identified mutations of a specific gene called RET, R-E-T, and we can identify children who carry this particular genetic mutation at birth or even before. And as a result, our current recommendation for the vast majority of children with this particular mutation is that they have their thyroid taken out early in life, sometimes as early as 5 or 6 years of age, certainly by the age of 10 to 15 years of age. And we can prevent spread of the cancer by doing that approach. Well, the primary therapy is surgery, and that would depend in part upon the stage, meaning the extent of involvement that we identify the tumor. So in the case of a hereditary case, if we take out the thyroid at age 5, we would take out the thyroid gland plus the lymph nodes that occur in the central portion of the neck. We wouldn't take out any other. And generally that is curative. On the other hand, the more common presentation for so-called sporadic or non-hereditary medullary carcinoma is when a patient presents with a thyroid mass or nodule. And in that situation, we would also do a total thyroidectomy, but because there's a reasonable probability that there will be spread to local lymph nodes, we would likely also do what we call a lymph node dissection. So that would be the primary therapy. There are other therapies that we use. For example, radiation therapy can be applied to the neck and upper mediastinum or the upper portion of the chest for patients who have extensive disease. We can also use radiation if there's spread of the tumor, say, to bone or sometimes to lung. And finally, if the tumor has spread to the liver or to the lung or other locations, we have newer therapies called tyrosine kinase inhibitor therapies that target the genetic cause of the disease and can cause shrinkage of the tumor. It's important that you understand that only surgery at the present time can be curative. Radiation therapy and the current targeted kinase inhibitors slow down and can shrink the tumor, but generally are not curative. Well, that depends on how far the tumor has spread at the time of diagnosis. So at MD Anderson, as we have compiled our survival, about 50% of patients who have no spread of the tumor beyond the neck will be alive 30 years later. Meaning that about half of them will have succumbed to the disease. But in general, it is a slowly growing tumor, and that largely directs our therapy. In other words, we're not going to be starting someone who has localized disease on any other therapy besides surgery, because we know that this person will, in many cases, have a prolonged lifespan, and since we don't have any cure at the present time besides surgery, we want to save those therapies for when they're really needed. Well, I think the first question is this genetic? Could it affect a member of my family? Did I inherit a gene for this from someone else? And that's important because we want to do the right thing for other family members also, and make sure that they're taken care of. The second would be, what is the appropriate therapy at that stage in the development of the disease? And we generally step back a bit and look more carefully at the whole patient, meaning, is the disease limited to the neck, or could there be spread of the tumor elsewhere? And that will have an impact on how we treat it. So we don't just dash into surgery the next day. We step back. This tumor, when diagnosed, has probably been there for years or decades. A week, two, a month or two isn't going to make that much difference. That is a difficult question. The fact is that medullary thyroid carcinoma is a rare tumor. There are probably no more than 1,000 to 1,500 new cases of medullary carcinoma in the United States in any given year. So that means that the average physician may see one case in his or her entire life. So given that reality, we would recommend that a patient be sent to a center of excellence. Now, the truth is that if a patient shows up with a thyroid nodule and it's a little unclear, even after a fine needle aspiration, what type of cancer it is, it's more likely that the patient is going to have surgery wherever he or she is located. And we live with that reality, even though we don't think it's optimal. It is what it is. Certainly, once the diagnosis has been made, the patient would benefit from being seen in a center of excellence. Well, immediate family members of a patient who has been diagnosed with medullary thyroid carcinoma should, first of all, insist that the patient affected with medullary thyroid carcinoma be tested for the presence of a germline RET proto-oncogene mutation. This is a simple blood test that is now done in many laboratories around the country and straightforward. That's important because it will determine whether this is hereditary or could be hereditary, and would dictate that family members need to themselves be tested for this possibility. The second thing that family members should focus on is to be supportive for the patient. Medullary thyroid carcinoma is a disease that generally evolves over years or decades, even as long as 40 or 50 years. And it's important to be supportive of the affected individual over that time period, and to be as helpful and supportive during that extended period of time. I think the most important thing is to think of this as, in most cases, as a disease that is going to evolve. And let me give you an anecdote. We recently had one of our medical residents whose brother was newly diagnosed with medullary thyroid carcinoma. And it turned out to be hereditary disease. The resident was tested and it was negative. But after the surgery, the family said, "What's next?" Well, the truth is nothing right now. And it's a matter of watching, waiting, and seeing whether this individual is in fact cured or not. And we know that the story will go on, that there will be other evaluation, perhaps even other treatment, but it is important to be patient and to think of this as a disease that evolves over years and decades, not one that is likely to cause death or serious morbidity in a very short period of time. So I think that's what I would consider to be the most important for a family.